At St. Elizabeth's, we have actually been quite successful over the years with diversification of various products and service offerings. We also have had great success with geographical expansion throughout the country. And from a growth point of view, probably since 2005 to now, we've had about 180% growth. Those are unusual statistics for in particular, nonprofit charitable organization. So the question you may ask is, how on earth have we been able to do that? So I think the first thing that's been critical, and I haven't heard a lot about this this morning or even in the beginning of our afternoon discussions, about a spirit of competition. It doesn't matter what tax structure you're in or how that model plays out. But competition, I believe, is the real engine to focus on the quality and the innovation. Competition, and from St. Elizabeth's point of view, if we are not competitive, then we do not have a place in the healthcare sector. When you look at the seriousness of that statement, you can see how culturally, in the processes of what we put in place for the organization, and in our own survival, how we put on a full court press to make sure we're competitive. So, what makes up that competitive world? Certainly quality and the definition of quality that every organization has. And I think the good news is we're moving to, in each organization, define quality. The challenge is that every organization in every sector is beginning to describe that in their own way. So when we move to paying for performance and paying for value, it's hard to differentiate what that looks like when we have all of the quality measurements. I share ours with you because you can see we not only have metrics for the organization, but we also have metrics for the community. Now, we feel strongly as a charitable organization, the wealth we create in communities is as necessary as the wealth we create within our organization as a business. So we have spent a lot of time in the competitive world that we are involved in and competing for home services, for community services, for consultancy work, for e-learning platforms with First Nations, all of the above, to demonstrate to the various funders our quality and the metrics within that quality. And for about 10 years, we've had a number of internal benchmarks and scorecards and data that we function internally to make sure we are responding minimally to what the funders are looking at, but also what we think are critical quality measures for the organization, both strategically and in what we're actually producing as an organization. We have also spent a lot of energy and time to get external validation of our quality. And whether that has been through third-party surveys and reviews where we measure, for example, our staff engagement now for over 8 years, to our National Quality Institute going for gold, all of those are to seek external validation of what we're doing and to keep us progressing in the field. The next area that's probably, I think, the most interesting area to look at innovation in both home care as a provider by virtue of being in people's home, that decentralized ring that Jason talked about, where the hospital is no longer the center, but the person in the home and the client who is pushing at us with mainstream technology. Now with a wireless environment, the use of the internet, and to be very frank, the use of the telephone to actually make visits virtual and to bundle services in a very different way. But also, innovation has been necessary for us as a provider because so much of our work, we have to demonstrate why the price has value. So we have put innovation in our business processes and our delivery models to increase productivity, to actually get greater throughput, so that we can actually increase wages and compensation because our delivery model becomes more cost-effective in what we're doing. So it's been a wonderful living lab for us to see. You really couldn't ask for the stars to line up as well for the environment we're in, with a ready audience, and with a real pressure for us to ensure what we do is competitive. At the end of this all, it really is to create value, and we're beginning to at least, I think, look at making sure that we're paying for performance or paying for activity. But I think there's now some great opportunity to be innovative with the pricing and to look at paying for outcomes, paying for the full episode of care, and leaping this up to another level. Right now, much of what we look at is the hour of care or the hour of the visit. And if we could change this to a whole episode of wound care, episode of diabetic intervention that crosses all of the sectors, then we could really push being competitive amongst ourselves within the healthcare system. So I'm just going to briefly walk through one example where I think we really have pushed both quality and an innovative approach in how we worked with the First Nations. And it's funny, when I was listening at lunch, I have always wondered with our work with the Aboriginal group why there's been such fast uptake with what we would probably define as disruptive innovation. And I can understand now why, because to some extent, we're not pushing through the status quo. In the areas where we've been able to move into new ways of creating wound care for diabetic foot ulcers, when the First Nations have 17 times more incident of amputations. They don't really care if the new model is different. They just want a model that could reduce the incidence of amputation. So there's been much greater uptake in how we have been able to help them not only understand and create a new wound care program, but also develop a whole wait times initiative with quality benchmarks for that. How we were able to do that, I think, was the culture that's been created at St. Eliz. And it started years ago where we put space and time and reinforced that getting ideas and having idea champions was critical to really embrace innovation. And so when we took on this initiative, we knew that we had to come up with new ideas in different ways to actually design what we were going to help them develop within 18 months' time. Another thing we did was try to get evidence out of not only best practices for wound care, but attempt to understand what are the best practices for innovating. And there's not a lot of information on that, and I think we're beginning in our own trial and error to try to make some more sense of that. At the end of it all, we created a tailored solution for this population that all at the same time we did assessment on the run, research on the run, implementation of a technology-assisted wound program, a policy position that foot care needed to be part of what we were trying to do, and then created a whole wait times program with effective touch points to what should be happening with the First Nations population in Manitoba. You can't do that unless you embrace quality and innovation in that time period, and unless you're open to it. So I think and hope that I've given you just a little bit of a perspective that this is achievable. And if we could actually bottle up the successes and the energy that takes place in this area, we can move forward throughout, I think, the whole healthcare system and make it more sustainable. Now, I'll leave you with sort of my last comments that, you know, the good news is that we feel we've been moving forward and making some great accomplishments. Our challenge is that there really is no end to this. And just as you can see with disruptive technologies and the companies that were yesterday and the ones that are today and then the ones that will be tomorrow, the finish line never is here. And I think in order to have a space for all of us in the system, we have to constantly embrace these concepts. So thank you so much for your attention.